Hello, anesthesiologists interested in TEE. This video presents a training course to help you learn the basics of TEE. Hola, anestesiólogos interesados en la ecografía transesofágica ET. Este video presenta un curso de capacitación para ayudarles a aprender los fundamentos de la ET. Welcome everyone to this deep dive into the clinical applications of TEE. Today, we are going to move beyond just the pictures and really get into the numbers, the data that helps you make critical decisions right there in the operating room. This is all about assessing cardiac function in real time.
So here's our game plan. We're going to kick things off with left ventricular systolic function, the heart's raw pumping power. Then we'll get into the really cool stuff, strain and strain rate. After that, we'll give the right ventricle some much-needed attention and talk about ventricular synchrony. Next up, we'll untangle the puzzle of diastolic function and learn how to grade it. And to wrap it all up, we'll see how to use all this information to calculate hemodynamics and evaluate preload. Let's get started.
All right, first things first, we're focusing on the absolute engine of the entire system, the left ventricle and its systolic function. We're going to build a solid foundation, starting with the basic metrics you'll use every single day, and then we'll move into some more advanced concepts that tell us about the health of the heart muscle itself. At the heart of it all, no pun intended, are the ejection phase indices. These are your bread and butter measurements. They basically answer the question, how good is the LV at its main job, squeezing blood out to the rest of the body? We get these numbers by measuring the change in the ventricle size from when it's fullest to when it's most empty. These are your go-to metrics for a fast, reliable snapshot of global function. So, let's look at two of the most common ones. First up, we have fractional shortening, or FS. Think of this as a simple, one-dimensional measurement. You're basically taking a single line through the ventricle and seeing how much that line shortens during contraction. It's quick, but it kind of assumes the whole ventricle is squeezing evenly. Now, fractional area change, or FAC, is a step up. It gives us a 2D assessment. Here, we trace the entire inner border of the LV in a short-axis view and measure the change in area. With a normal value around 60%, it gives you a much better picture of what's really going on, especially if you suspect a regional wall motion problem. And that, of course, brings us to the most famous player in the game, the ejection fraction, or EF. This is the big one. It's the cornerstone of how we assess global systolic function. EF is all about volume. It tells you what percentage of blood in the left ventricle gets pumped out with every single beat. Now, it can be influenced by things like preload and afterload, but it's still the most widely understood and clinically important measure of the heart's pump.
But what if you want to know how healthy the muscle itself is, kind of separate from loading conditions? For that, we can look at isovolumic phase indices. Isovolumic just means same volume. It's that tiny slice of time after the mitral valve slams shut, but before the aortic valve pops open. A great metric here is the circumferential fiber shortening rate, or VCF. This isn't just about how much the fibers shorten, but how fast they do it. Because we measure it before the aortic valve even opens, it's considered less dependent on preload, which gives us a clearer window into pure myocardial contractility. You're looking for a normal value of about 1.2 circumferences per second.
Okay, so we've got those fundamental concepts down. Now let's peel back another layer and get even more detailed. We're moving beyond just measuring size and volume to look at the actual mechanics of the heart muscle, how it deforms, twists, and shortens. This is the world of myocardial strain and strain rate, and it is an incredibly powerful way to spot dysfunction way before the EF ever changes.
Now this is just beautiful. This slide shows you why the heart moves the way it does. The myocardium isn't some simple sack of muscle, it's this incredibly organized complex structure. You can see the fibers are arranged in these crossing helical layers. This amazing design is what lets the heart move in 3 dimensions at once. It shortens from top to bottom, it thickens from the inside out, and it twists like you're wringing out a towel. Understanding this architecture is absolutely key to understanding strain.
So what exactly is strain? Well, myocardial strain is simply a measure of that deformation we just talked about. It tells us how much a piece of the heart muscle has changed its shape, and, this is the important part, it's expressed as a percentage of its original length. The formula looks simple, and it is. It's just the final length minus the starting length divided by that starting length. It tells us, for instance, that a segment of the heart shortened by 20%. Okay, so if strain tells us how much the muscle deforms, strain rate tells us how fast it gets there. It's simply the strain divided by how long it took for that change to happen. And this is so important because in a lot of diseases, like early ischemia, the speed of contraction can be affected long before the amount of contraction is. That makes strain rate a super sensitive marker for spotting trouble early. And here's a perfect example of how we put those formulas to work. What we're looking at is an M-mode tracing through the LV wall.
First, we measure the wall thickness when the heart is relaxed. That's our initial length, L0, which is 1.1 centimeters here. Then we measure it at peak contraction. That's our final length, L1, which is 1.5 centimeters. You plug those numbers into the formula, and boom, you get a radial strain of 36%. The machine can also tell us that this all happened in 275 milliseconds. Do the division, and you get a strain rate of 0.13 per second. It's a real, hard number for regional function.
So how do we measure this stuff? Well, one of the main ways is with Doppler tissue imaging, or DTI. The idea here is that we tweak the Doppler settings on the machine. We tell it, hey, ignore that fast-moving, low-signal blood flow for a minute. I want you to lock on to the slow-moving, high-signal heart wall. By measuring the velocity at two different spots, we can figure out the velocity gradient between them, and that's how we calculate strain. The big takeaway here, because it's based on Doppler, it is highly, highly angle-dependent. Your alignment has to be just right.
And this is the kind of graph you'll see. Panel A on the left is the strain curve. That lowest point on the curve represents the maximum shortening, or the peak systolic strain. But look closely. See how sometimes the muscle keeps shortening just a little bit after the aortic valve has already closed? That's called post-systolic strain, or PSS, and it can be a subtle sign of ischemia. Panel B over on the right shows you the strain rate, which is just the speed of that deformation over time. Now, to really understand these graphs, we have to be specific with our terms. This table really helps. End systolic strain is the amount of deformation at the exact moment the aortic valve closes. Peak strain is the absolute maximum squeeze, which, as we saw, can happen just after the valve closes. That difference between the two, that's your post-systolic strain. We also look at the peak strain rate and, of course, torsion, that ringing motion of the heart we talked about. Now, remember how I said DTI is so picky about the angle? Well, that led to the development of another amazing technique, Speckle Tracking Imaging, or STI. And this is a real game changer, because it's not a Doppler technique. Instead, the software identifies these little natural acoustic patterns in the heart muscle. We call them speckles. Then it just tracks those patterns frame by frame as the heart moves. By following that constellation of speckles, it can calculate deformation in any direction, making it pretty much angle independent. This table gives you a fantastic head-to-head comparison. DTI on one side, it's Doppler-based, so it's very angle-dependent and really only measures strain in one direction. But its big advantage is its excellent temporal resolution. It has very high frame rates. STI on the other side, it's image-based, angle-independent, and can measure strain in 2D. Its major weakness, though, is that it absolutely requires a crystal-clear image for the software to work properly. You've got two great tools in your toolbox, and it's all about knowing which one to use and when.
All right, we've given the left ventricle plenty of the spotlight. Now let's turn our attention to its often overlooked but incredibly important neighbor, the right ventricle. We'll also dive into why it's so important for all the different parts of the heart to contract together in perfect time.
You know, the right ventricle isn't just a smaller version of the left. It has its own unique personality. For one, its longitudinal strain is actually greater than the LVs, and it's not uniform across the wall. And because that RV free wall is so thin and sometimes hard to see well, strain analysis becomes a fantastic tool for spotting ischemia. We also come back to this idea of rotation and twist. That ringing motion, with the top and bottom of the heart twisting in opposite directions, is just critical for an efficient pump. When you lose that twist, you know you're in trouble.
Now, timing is everything. It's not just about how hard the heart contracts, but whether it contracts all at once. Ventricular dyssynchrony is when different parts of the ventricle are out of sync. It's totally inefficient. It's like trying to row a boat when everyone is paddling at a different time. You just waste a ton of energy. With advanced TEE, we can actually create these color-coded maps that show us these timing delays, helping us spot patients who might need something like cardiac resynchronization therapy. We've spent so much time talking about systole, the squeeze. It's time to pivot and talk about the other, equally important half of the story, diastole. That's the relaxation and filling phase. You can have a heart with a perfectly normal ejection fraction that's still in failure because it's too stiff to fill properly. So let's dig into how we figure that out. Evaluating diastolic function is really like being a detective. You have to gather clues from a lot of different places. First, you look at the left atrial size. A big LA is a sign that it's been fighting against high pressures for a while. Then you do your transmitral Doppler, which gives you that classic E wave for early filling and the A wave for the atrial kick. The E to A ratio is always your starting point. After that, you can look at the pulmonary venous flow, color M mode, and most importantly, tissue Doppler, which measures E prime. That's the speed the mitral valve base moves, and it gives us a direct look at how well the muscle itself is relaxing.
All right, this is a really crucial part of our session. You have all these different parameters, so now what?
How do you put them all together to come up with a clear diagnosis and actually grade how bad the diastolic dysfunction is? It might seem complicated, but there's a very clear step-by-step process we can follow.
Okay, here it is, the complete algorithm for classifying diastolic dysfunction. Now, I know this looks like a lot on one slide, but don't worry. We're going to break it down piece by piece. Think of this as your decision-making roadmap.
Let's walk through it. Step 1 is your first checkpoint. Just look at 3 things: your septal E, your lateral E, and your LA volume. If all 3 of those are in the normal range, you can stop right there. Diastolic function is normal. If any of them are abnormal, you move on to step 2. Now you're going to look at your E to A ratio, your deceleration time, and your E to E prime ratio. Step 3, finding grade 1 dysfunction, is usually pretty easy. It's a delayed relaxation pattern, and you'll see that classic E over A ratio of less than 0.8. Finally, step 4 is telling the difference between grade 2 and grade 3. Grade 3 is restrictive and usually has a very high E/A ratio. Grade 2 is what we call pseudonormal, because the numbers can trick you into thinking they look normal, but when you put all the clues together, you know they're not.
And for our final section, we're going to use TEE as a true hemodynamic monitor. This is where we take all these images and turn them into hard numbers that can guide your management of fluids, pressors, and intratrips, minute by minute.
This is one of the coolest things we can do. We can actually estimate the pressures inside the heart without a single invasive catheter. The magic trick here is the modified Bernoulli equation. All it says is that we can convert the velocity of a jet of blood into a pressure gradient. So, you find some tricuspid regurgitation, you measure how fast that jet is moving, and you can calculate the right ventricular end systolic pressure. Same idea for aortic regurgitation. The velocity at the very end of diastole can give you a great estimate of the left ventricular end diastolic pressure.
And of course, one of the most powerful things TEE can do is measure cardiac output directly. We all know the formula. Cardiac output is just the stroke volume, how much blood gets pumped with each beat, times the heart rate. And with TEE, we can calculate that stroke volume accurately for every single beat.
So how do we get that stroke volume number? The most common way is to use Doppler to measure blood flow going through the left ventricular outflow tract, or LVOT. Just think of the LVOT as a pipe. First, you measure the diameter of the pipe to get its cross-sectional area. Then you use Doppler to measure how far a column of blood travels down that pipe with one beat. That's the velocity time integral, or VTI. You multiply the area of the pipe by the distance the blood traveled, and that gives you the volume. That's your stroke volume.
And last but not least, let's talk about preload. How full is the tank? TE gives us 2 great ways to figure this out. The most direct way is just to measure the size of the left ventricle at the end of diastole, the LVEDV. You can do this in 2D or even 3D. The other way is to estimate the filling pressures, and for that, we come back to our old friend, the E over E prime ratio. It correlates incredibly well with left atrial pressure. If that ratio is high, you can be pretty sure your filling pressures are high. We've covered a huge amount of information today, from the simple to the complex. We've seen how TEE takes us from just looking at the heart to truly quantifying its function. So I want to leave you with this question to think about. How can these advanced metrics actually transform your decision-making in the middle of a tough case? How will this change how you give fluids when you start a pressor, or how you titrate an inotrope, all to get a better outcome for your patient? That, right there, is the true power of intraoperative TEE.